So you're bringing a face transplant program here. The entire concept of doing face transplants is only a few years old. I'll just tell the little story. I was getting a tour here. I was here for a personal reason. A friend of mine is one of your doctors, and he was walking me around your facility, and a patient came over, and I shook his hand and so forth, but I didn't realize until he told me later that he was a face transplant. I could tell there was some work done, but he didn't look like some of the face transplants I'd seen on the press. So it was a really good result. I mean, everything was in place. He was talking. So there was a dramatic, socially acceptable outcome.
Sure.
So why don't you tell me, please, so you started this in Maryland, and then what is a face transplant team is, tell us a little bit about that. How many people involved? It's a 10-hour case, or how does it work?
So I'll just tell you a little bit of the inception of the program. When we started in Maryland, the whole purpose was to care for the wounded warfighter. Mm-hmm. And we applied for a grant which was through the Warfighter Protection Program, mm-hmm. offered by the Office of Naval Research. We wanted to offer our soldiers, those that would sustain significant casualties as they focus on the face, an opportunity to restore them back to normalcy. Mm-hmm. So we began this venture. It all began on the basic science, and we worked with a large animal model trying to define and structure how it would work with a face transplant. That began quite a while ago. The first face transplant was performed in 2005 in France, in Lyon and Amiens, through Max de Bernard and Bernard Duvachel. Now, we can recall we were going through some very difficult times during that time. We were involved in some significant wars. Mm-hmm. And during that time, we also started having significant military casualties. Now, we realized that we had to not only build a basic science foundation, but we had to structure a clinical program. We fast forward the clock. We applied for an IRB. It's an institutional review board. Since these patients are considered research patients, it's a research program. They're not your standard patient. They go through a very rigorous vetting process, very rigorous regulatory process, where a group of physicians, not just surgeons, a number of different specialists,
psychiatrists,
clinical psychologists, transplant psychiatrists, immunologists, transplant surgeons, ethicists, it's a huge component, decide as a group with voting rights, do we move forward with this patient or not? We decided to move forward with one of our patients, Richard Lee Norris, and he was ultimately...
That's the patient I met.
That's the patient you met. He was
you're still talking about Maryland now.
Correct.
But he's up here because you're here, yeah.
Correct, and we performed that face transplant in March of 2012.
And he was a gunshot wound.
That is correct, a self-inflicted gunshot wound.
Damaged his jaw, upper jaw.
Correct, so he was missing lower jaw, upper jaw, no teeth, a good portion of his tongue, did not have nose, did not have cheekbones. A lot of the surrounding facial soft tissues had been used, specifically the forehead, to reconstruct the nose. So he had what I would consider consequential surgical stigmata from attempts at restoring his facial form. Now, we rehearsed his exercise through a number of cadaver rehearsals. We performed at about 15 paired occasions, trying to develop what I considered a procedure which would not only restore function, but would be elegant enough to restore his appearance so that most individuals would not appreciate that he had been a face transplant patient. They would appreciate that he had had some surgery. There were obviously incisions, but they wouldn't be right in front of you in the manner that we had seen with previous patients. Significant skin color mismatch, significant facial dysmorphometry with regards to differences in the type of the facial skeleton. So we wanted to make sure that the skeleton fit, the soft tissue fit, and that the skin color mismatch was as least as possible. And that was performed in March of 2012. Fortunate with great success. As you mentioned, he had a great result. And now we're involved. Since I transitioned up here, he shares part of his care up here in New York as well as in Maryland.
So how's the healing? Are the muscles in his face working?
Yes.
And is the sensation, can he feel?
Yeah, so he can feel. It's a little altered, different than you and I. but it's pretty good considering we were not able to connect any of the sensory nerves. Our goal was to connect the sensory nerves. We included in the face procurement, in the donor face, we did have the sensory nerves. However, in the recipient face, Richard's face, we could not find the target nerves because they were so badly injured.
But they somehow have grown around.
Somehow or another, he does have sensation throughout the face. Where he likely has it mostly diminished is in the lower lip and the chin, because we were not able to connect the inferior alveolar nerve, which is the lower face sensory dermatome.
Yeah, if it was blown away, the root would be
really way posterior by the ramus of the mandible. Now, on a motor function, what you see in his face, those are the muscles of facial expression from the donor that were connected. The nerves to those muscles were connected to Richard's recipient nerves, and that's why he has facial animation. So his nerves, his cortical input from his brain is moving the face of the donor.
That's amazing. Did it take him a while to learn, relearn?
Absolutely.
Which,
absolutely.
Because not all the nerves are properly connected. So.
Correct. And he also had what we define as synkinesis. When you have significant facial injury, a lot of the nerves from a blast injury, as in his case, the nerves, they kind of get tied together, so if you blink, you smile.
Sure.
So trying to correct a lot of that, so we limit the amount of synkinesis, although he has some, much better than he was before. And I think what's also very important, that we did preserve his corneal blink, because he did have relatively normal vision, slightly diminished after his initial gunshot accident, and it's slightly diminished after I performed the first revision. The other thing that we spent a lot of time publishing to try to educate other centers and other surgeons, and one of those components has been performing revision surgeries on patients who have undergone face transplant.
So he can see, and his eyes are lubricated with a blink.
Yes.
He can eat.
Yes.
His jaw, I saw him speak, so he can speak. The impairment's from the tongue, which was from the injury, I'd imagine.
Sure.
And his lips don't work perfectly, but
Correct.
And he can eat normal food?
Yes. So
wow, that's huge.
As a matter of fact, we have him scheduled here soon. We're gonna. He doesn't have a tracheostomy anymore. He doesn't wear the trach tube, but he has a small fistula, which I will soon close. And he's had a peg for a while. And I've been somewhat reluctant to remove the peg because it doesn't really use it for nutritional supplementation. And exactly as you mentioned, the motor mechanism is not like yours or mine. But overall things work. Smiley mechanism is not as symmetric as we would like it to be. The tongue does not move as ideally as we'd like it to move, although I transplanted the anterior 1/3 of the tongue.
Oh, okay.
The posterior base of his tongue is still scarred and with some injury, so
Is he tasting?
He can taste. But swallowing a bolus, he can do so. I think it's time to remove the percutaneous gastrostomy feeding tube.
And so next, now you've got a patient lined up to operate here at NYU, and how far away is that?
So that patient has been listed. He's gone through the rigorous regulatory process. Our team has rehearsed, so we have a core surgical team that's made up of about 7 people. However, the team is much larger than that because of all the specialists that are involved and all of the ancillary assistants, from the surgical nursing to scrub techs to physician extenders, nurse practitioners, physician assistants. So it's a big program.
Is it like a liver where you have to, let's say you're ready to operate, then you're waiting for the donor to show up, and then you get a call like a liver and you've got to go rush out and get it? Or is it more planned than that?
We're not just there, Steve, I'll tell you, because first of all, starting a new program now at NYU, we're not at that position yet where we've done so many that we feel comfortable. I'm still apprehensive and anxious. So the way that we have it set up in the state of New York, if we identify a donor within the state that match the criteria of our recipient, that donor will be transported to NYU. We will perform the recipient and the donor operation concurrently in side-by-side operating rooms at NYU Langone.
Interesting. And
ultimately, it will get to that point where we will have what we call a go team that'll go procure while the recipient is being prepared at NYU.
Okay. So you have more time with the donor. They're brain dead or something, so they can be transported. And
correct.
Okay. I suppose we could have done that with livers too. It was just easier to go get the liver than,
Right.
Okay, now I'm interested in, I'm seeing heart transplant patients win on the PGA Tour and so forth, and so I looked into this, but the immunosuppression is not as toxic as it used to be. What is it again? Is it just one drug pretty much? Or?
Well, there is one program that's going to one drug. I'm not a strong advocate of one drug, and the reason for that, I rely greatly on my transplant surgery colleagues. And I think we have pretty good medication right now that can manage these patients pretty well. I think a face transplant is experimental enough as it is. I wouldn't want to add additional experimentation in a regimen that's working so well. However, the medications that are being used for even our liver transplant patients have been reduced dramatically. Most patients now, as Richard, they're essentially on 2-drug regimen. Most of it is Prograf, and that's fortified with mycophenolate, and sometimes they just keep them on very low dose prednisone, depending on the episodes of rejection. But ultimately, the goal is to just keep them on one medication, which ultimately will be Prograf.
The life expectancy, I mean, tumors and cancers,
those are big concerns, and they exist still, and that's why we want to reduce the amount of medications. We know that these types of immune suppressive medications can affect these protective mechanisms that exist in our body, and basically open the gates to malignancies and things that you mentioned.
So you bring the donor patient, you start operating on that. From the time that clock starts, how long does that take to harvest? Several hours?
So based on our previous experience in Maryland and what we practice here, the procurement of the face took about 14 hours.
Wow.
And the difficulty is, unlike a solid organ where you just get to the major vessels and just some stromal dissection, here you have to identify all the nerves, all the muscles, all the blood vessels. The one that we have planned to perform at NYU will be of the same level of complexity. So while the donor operation is going on, which may take 12 to 14 hours, the recipient operation is basically being prepared for acceptance of the donor face. In Maryland, the entire operation took us about 36 hours from